Good evening. I have 7 o'clock Eastern Time on my clock here, so we will go ahead and get started. PRC-Saltillo is excited to offer this guest presentation, Augmentative and Alternative Communication and Childhood Apraxia of Speech, Ideas and Resources. My name is Lisa Tim, and I am the Implementation and Training Manager at PRC-Saltillo, and I will be your moderator. Our presenters are Kathleen Post and Michelle Retzloff. Kathleen is a clinic coordinator and an associate professor at Midwestern University's Speech Language Institute. She teaches courses in augmentative and alternative communication and supervises SLP graduate student clinicians at the Speech Language Institute in all facets of speech and language service. She presents frequently in the area of AAC assessment and intervention. Previously, she was the Director of Assistive Technology, Speech, Language, and Nutrition Departments at a large pediatric outpatient rehabilitation center in Illinois. For over 30 years, Kathleen Post has served individuals with communication challenges and their families. Her areas of interest continue to include pediatric speech and language disorders, early intervention services, augmentative and alternative communication, and assistive technology for persons of all ages and disabilities. Michelle has worked within the field of assistive technology and alternative and augmentative communication since graduation by primarily serving individuals with significant communication deficits. Prior to joining Saltillo, Michelle worked as a speech-language pathologist for a large urban school district serving students who ranged in age from 3 to 21 with a variety of diagnoses. Michelle worked at a level 1 trauma hospital in the subacute setting, providing therapeutic services to adults with a variety of acquired language and swallowing disorders. At her previous employers, Michelle had the opportunity to work closely with other professionals on a multidisciplinary team. She prepared various communication strategies, including low-tech solutions to high-tech devices while at the school and hospital settings. She had the opportunity to plan and implement therapy targeting the use of various communication systems. Furthermore, she has experience of providing technical support and implementation strategies to teachers, clinicians, and family members of device users. A little bit of housekeeping. If you should have difficulty with the GoToWebinar platform, our first suggestion is to try logging off and logging back in. We are unable to troubleshoot during this class, and you may be able to work with the LogMeIn staff to get connected. The materials are available in this toolbar, and you should find the ASHA participation form, the instructions for submission, a certificate, and then 2 session handouts. These handouts are PDFs that are fillable. Please note that you will only be able to download them through this live training. You will also find a feedback survey is launched at the end of the class as you are exiting. We appreciate your feedback as it helps us to improve our offerings in the future. Please type your questions in the chat window. We will be monitoring the chat window during this session, and our presenters will answer questions towards the end of the session as time allows. In order to submit your ASHA participation form, we ask that you submit this within 15 days of your attendance today. Please include the date of the training on the form. This will be how the training attendance is verified and recorded in our system. Your entrance and exit of the training is timestamped through the GoToWebinar platform. You must stay online for the entire training in order to receive credit. When submitting your ASHA form via email, please include the title of the class and the date of the class in the subject line. This helps our processing department align your attendance with the appropriate class. This class is offered for 1 hour of ASHA credit, and these are the disclosures of our presenters. Kathleen does not have any financial disclosure and is not receiving compensation for this webinar. She is a member of ASHA, ASHA SIG 12 and 11, and Michelle is a full-time employee owner of Saltillo. Michelle is also an ASHA member and an ASHA SIG 12 as well. And now I will turn this presentation over to our presenters. So I will make you a presenter, Kathleen. And let's see.
Okay. Good evening, everyone.
Hi, everyone.
I would just like to welcome you all to tonight's presentation on augmentative and alternative communication and childhood apraxia of speech, ideas and resources. First of all, I just want to express that we both hope that everyone that's joining us is all well and safe during this unprecedented time in our history, and we hope that you will find the information that we're sharing today really useful. We're excited and thankful that you've taken time out of your day to spend an hour with us. We hope that you enjoy the topic, you find it relevant to your current or future therapy practice, you find it intriguing and maybe want to delve more into it, because of course we cannot cover everything, and that if you are doing these kinds of activities, that you find it affirming for the work that you're doing with children who have suspected childhood apraxia of speech or apraxia of speech.
There is a corresponding handout in the materials section, and we wanted to point out that it's not your traditional handout. So we don't provide all of the slides that are going to be in tonight's presentation. Rather, we wanted to highlight certain points that we felt were key elements or points of discussion, and we allotted some room so that you could jot down some notes or maybe some ideas that might spark something during our discussion during tonight's webinar. So with that, we're going to hide ourselves, and then we'll pop back on towards the end of the webinar. So I'm going to hide the camera here.
Okay, so I'm hoping that all of you will be able to see my slides here.
I can.
Michelle, you can?
I can.
Yes, great, excellent. Okay, let me just get started here. All right.
So Lisa provided a professional description of who we are, but how did the two of us actually connect to present on this specific topic? During my years as a Saltillo consultant, Kathleen and I have worked together in various facets, and the collaboration on this particular topic was a wonderful happenstance. I was actually participating as a vendor in an exhibit hall at a national Apraxia conference, and it turned out Kathleen was attending. And as we started chatting, we both had a hunch that AAC and CAS had some overlap. And with our passion for AAC, we set out to investigate a little bit more.
You know, we had a lot of questions about how individuals were using AAC with their treatment protocols for childhood apraxia of speech. So that curiosity led to an investigation into the information that was available. We're both in the teaching and information profession. We both have a love for AAC and for those needing this kind of support, particularly young children. And we thought this would be a really great topic to learn more about and, of course, share what we've learned. But before we get into all of that, we really want to know who you all are. So we've got a poll, so if you wouldn't mind tuning into that and giving us some answers.
Thanks to everyone who's participating in that poll. Keep the results coming in.
And this really just helps us know what kind of background you all have, and helps us know what kind of material we can move quickly through and what we should spend a little more time on. So we really appreciate you sharing this.
And I'm back. My computer froze, but I will go ahead and close the poll.
Okay, great.
Thanks, Lisa.
Okay, terrific. All right. So it does look like a number of you are SLPs, which we of course expected, and then we have still some individuals who are parents or caregivers and teachers or paraprofessionals and AT professionals. So that's wonderful.
In addition to knowing who's here, we have another poll, and we would love to know your honest thoughts on combining AAC and CAS treatment. So here's our next poll for you all. I'm loving the honesty. I'm seeing this is great.
And you had a few in the chat that also said, love it, that couldn't seem to take the poll.
Okay,
Thanks.
great. That's terrific. So, you know, you can never have too much of a good thing. And we have one more poll, and I promise this is our last one. Now that we've captured your feelings on childhood apraxia of speech and AAC and who you are, we want to know, are you really using AAC in your treatment with children with apraxia of speech? Now remember, these are anonymous polls, so no worries here. Lisa?
I launched it.
Yeah, we could see that. Great.
Okay, so you have a few that are not able to take the poll. I'm not sure, depending on their platform, but so some have said that you've got probably 3 or 4 that say they've incorporated it. Some that have said that it's a game changer and that they've used it. So you just have a couple extras on those 2 categories.
That's terrific. And
Thank
you know,
you.
this again helps us know that your perspectives and what you're thinking about. And we hope that the information that we continue to provide to you in this session will be affirming and support, and you'll be able to pull some nuggets out that will be useful for you as you go forward in your practices. Michelle.
So with that, we had to set forth some learning outcomes, and what we set forth for tonight's webinar is that participants will describe treatment strategies involving AAC supports for children with CAS or suspected CAS. Participants will develop a plan of action to incorporate AAC into current treatment methods for children with CAS or suspected CAS. And participants will be able to identify resources for implementation and integration of AAC with treatment methods for children with CAS. Which leads us to our agenda. Our agenda for the evening we will define AAC and CAS. We will discuss current perspectives about usage of AAC, and then we'll provide a brief overview of an informal survey we conducted. And then we'll also present a few case studies that integrate AAC and CAS. And then we'll wrap it up by providing a bunch of resources and conclude with some questions and references. So let's begin. ASHA, or the American Speech, Language, and Hearing Association, defines childhood apraxia of speech, or CAS, as a neurological childhood speech sound disorder in which the precision and consistency of movements underlying speech are impaired in the absence of neuromuscular deficits. CAS may occur as a result of a known neurological impairment in association with complex neurobehavioral disorders of known and unknown origin, or as an idiopathic neurogenic speech sound disorder. The core impairment in planning and/or programming spatial temporal parameters of movement sequences results in errors in speech sound production and prosody. So what does CAS actually look like? When we look at the ASHA portal, it has a lot of information related to CAS. Of note, they delineate characteristics into primary and list multiple co-occurring areas that CAS may actually impact. When we look at what some of those primary characteristics include, it could be inconsistent errors on consonants and vowels and repeated productions of syllables or words. It might also include lengthened and disruption co-articulatory transitions between sounds and syllables, and inappropriate prosody. In addition, CAS may impact language development, expressive language skills, literacy skills, and pragmatics. So when we look at how many areas CAS can impact and the rapid rate at which speech and language skills can develop, we might find ourselves in searching for some type of support options to supplement the decreased verbal skills while allowing access to robust language. Many with CAS have receptive language skills that exceed their verbal speech. So we might be finding ourselves asking the following: what can we provide our clients, our students, our children, so that they have a method or access to consistently expressing what they want to say or what they know?
So along with that definition, we thought it was prudent to also define a couple of other terms that we're going to be talking about tonight. And of course, a big one is augmentative and alternative communication. ASHA describes this as any system or method, and we know that that could be very broad-based. It can include gestures and signs, body language, picture exchange, communication boards, letter displays, and devices of all ranges, from low to high-tech, iPads with apps and Androids with apps, that replaces or supports natural speech and provides a means for someone to communicate. It also addresses the area of research, clinically and academically, that focuses on individuals who have severe speech disorders, on their ability to participate in their environment, and what their impairments are like and how it's affecting their ability to participate and be active in the world around them. I wanted to also add a couple of other terms that we're going to be discussing later today, and one is aided language stimulation, or sometimes it's called partner augmented input, sometimes it's called aided language modeling. I think that a number of people use some of those terms interchangeably, but it really refers to the process of using a communication display, typically one with voice output, but it doesn't have to be, as you are speaking. So you, as the communication partner, are using a communication display while you are talking. You're selecting icons or words on that display that match what you're saying as a model for how language could be constructed and produced on that system, on that board, or on that device for your child or your student. The other area that we'd like to just briefly talk about are the competencies for AAC. A lot of us have learned that there are 4 major areas of competency that we look for AAC communicators. We look for them to be competent in their social skills and in using AAC socially. We look for them to have competency in linguistic use of their AAC systems, that is, using them for language, to produce language, to communicate. We also look for competency in their strategic use of their device. When do they use it, and with who and where? Do they understand how to modify their usage based on their environment and be strategic? And then finally, that operational competency. Do they know how to do some of the operational functions of a device if that's what they're using? Or if it's a communication book, do they understand how to turn the pages and get to the sections they need if that's appropriate? There is a 5th competency area about emotional competency. That is, are they learning to express their emotions and their feelings? And in this day and age right now, for me, that's a big push that I have with a lot of children that I'm working with, is, do you know how to go to those areas on your communication supports to share your worries or concerns and express your emotions appropriately? So that's another area that's relatively new that is being looked at as a competency. When we also talk about AAC, it really also behooves us to take a little bit of a look at some of the myths that still persist. I don't know about any of you, but I know that in the work that I'm continuing to do with families and professionals, I still am approached with the concern about introducing an AAC system and it limiting or inhibiting the development of natural speech. And that is a primary myth that we need to continue to refute and continue to show research to those individuals to help them understand and feel confident that introduction of something like this will not interfere. So The ASHA portal, again, has some wonderful research and citations that AAC does not affect motivation to use natural speech. It can help improve it when therapy focuses simultaneously on natural speech and the use of AAC in a multimodal approach. In addition, intervention for minimally verbal school-age children with ASD, autism spectrum disorders, and those individuals might have co-occurring diagnoses of childhood apraxia of speech. When that intervention included use of a speech-generating device, it increased the spontaneous output and use of novel utterances compared to the same intervention that did not include that. Very powerful research. And of course, AAC can help decrease the frequency of challenging behaviors. And we know children with CAS, depending on the severity of their diagnosis, can become very frustrated and upset when they aren't able to communicate. Another myth that seems to persist is that young children aren't ready, that there's a readiness behavior that's needed before we introduce an AAC system. And again, in ASHA's practice portal, which we hope you'll go to find more information about these pieces of research, it tells us that early implementation of AAC can actually aid the development of natural speech and language. It can increase vocabulary for children ages 3 and younger. When we use it with preschool children, we're seeing an increased use of multi-symbol utterances where they're putting language together and the development of grammar. And it can lead to an increase in, of course, receptive vocabulary and comprehension. And then finally, this last myth that there is some sort of prerequisite skill that is needed, such as cause and effect or showing communicative intent. And again, the practice portal tells us there's research to support that impaired cognition does not preclude communication, that individuals who have impaired cognition can, of course, learn to communicate. And development of language skills can lead to that functional cognitive gain as well. And then finally, that AAC intervention for children with these types of complex communication needs helps develop that functional communication skill and promotes cognitive development, foundation for literacy, improves social communication. It all around has very positive effects. And I know that since a lot of you are using AAC, I might be preaching a little bit to the choir, but we wanted to make sure that you had these references and that we revisited this to further strengthen your ability to explain and provide rationale to families that may still have questions about this.
So that leads us to our inquisitive side. We wanted to know if low, mid, and or high-tech AAC was actually being incorporated into CAS treatment. From that curiosity, we created a very informal survey, and we asked a variety of questions related to CAS and AAC. The survey was posted in 2017 to various Facebook groups. We shared it with personal and professional contacts, as well as new SLP clinicians. And then we shared this again in 2020 to the same groups of people. We wanted to see if there were any changes in the participant responses. So due to time, we are going to highlight just the results, again, from the informal survey that we found to be of particular interest. One of the first questions we wanted to ask was, hey, is there a formal diagnosis of CAS with any of the clients, children, or students you might be working with? The chart on the left represents the responses from 2017, and the right displays the responses from 2020. There are many things that we could say about the information provided, but one that we thought we would highlight was, in 2020, 29% of respondents reported that they did not have any clients with a formal diagnosis of CAS, compared to 12% reported in 2017. Looking at the graphs, it's just interesting to see the distribution over the years. We had a hunch that some respondents would state that a formal diagnosis was not provided, which prompted us to ask the informal survey question, do you have any clients, students, or children who have suspected CAS? Looking at the graphs, you'll notice some differences in reporting. Of note, in 2020, 43% reported that there was more than one child with suspected CAS on their caseload, compared to 17% reported in 2017. Just some really interesting data.
So along with that, we also as SLPs were interested in what kind of intervention methods and approaches the people who were filling out the survey were engaging in with children with childhood apraxia of speech or suspected childhood apraxia of speech. And as you can see, we listed a variety of different treatment approaches, and this is not an all-encompassing list by any stretch of the imagination, but these were things that we knew that people would maybe recognize in the field and select. And we had another category that people could write in, and several people wrote in motor learning theory or REST, the rapid syllable transition therapy, as an option that we did not have listed here. What's interesting to note is the orange bars are the results from 2017, the green are 2020. And in 2017, you can see that AAC, Kaufman speech to language protocol, and the combination of treatments methods were stronger, were more strongly used by more people on the survey. In 2020, we seem to have a little more even distribution, but AAC continued to be widely used, as well as the combination of treatment strategies. Now, of course, when people said they used AAC, we wanted to know what kind of AAC did they use. And this graph shows you what they responded. Again, orange is 2017, green is 2020. And we saw in 2017, we saw more people indicating that they were using a high-tech system like an iPad with an app or an Android with an app or a dedicated speech generating device. And then a combination of options as well. But in 2020, we're seeing a little more even distribution with a little less in high-tech iPad apps and dedicated devices, and a little more in a combination of options, which we found very interesting as well.
Continuing the questioning about AAC, if AAC was incorporated into therapy, we inquired about the perceived speech and language progress that the child possibly made with incorporation of AAC into CAS treatment. 2017 had reports of more significant verbal speech production progress, while 2020 seemed to be more evenly distributed. Of interest, in 2017, respondents reported more use or incorporation of high-tech AAC and use that high-tech AAC for longer periods of time. Could there be a correlation? Could the use of high-tech AAC for longer periods of time equal more perceived verbal speech production? We'd like to stress that this is being obtained from an informal survey, so the jury is still out, but it does pose an interesting question.
Maybe someone in our audience will think of doing a research study on that, which I'd love to partner with.
Lovely.
So, yeah, that would be great. That would be great. Yeah. In this survey that we did this year, we added another question that we didn't have in the 2017 survey. And it was really about what were they doing with the AAC system? What was the focus? Was it primarily a strategic focus to supplement? Was it for social purposes? Was it for linguistic growth? Or was there a focus at all, or was it everything? And as you can see on this particular slide, it was a little bit of all of those pieces, which was exciting and encouraging for us to see as well.
So what are our takeaways? We definitely know that this survey is not scientific in any nature, but it does offer a small glimpse into what might be happening in the field of CAS and incorporation of AAC. We would have loved to have more respondents, because if we have more respondents, then we would have had more data, which we could have shared. We also know that we provided the survey and directed it at groups which more than likely were already using AAC or incorporating AAC into said treatment. We also had more speech language pathologists who participated in the second survey. With regards to the progress, oh, go ahead.
Keep going.
Okay, sorry. With regards to progress, we didn't provide an explicit definitions in regards to the words moderate, significant, or limited. Therefore, we're not sure how respondents may have interpreted these words. Limited progress for one child could actually mean significant progress for another child, because CAS presents so differently.
the positive takeaways was that the information seemed to correlate with the research that really supports the use of AAC in a multimodality format in conjunction with verbal speech treatment protocols, and that AAC continues to be an option that's being explored. So we were very encouraged again to have that support coming forward. One of the things that we did want to move to talk about, so after we had this survey and we were looking at the results and we were thinking about how AAC is being used in therapy, one of the ways that I have learned to use AAC for children with apraxia of speech is to incorporate a decision-making process using this multi-tier model for AAC usage by Ball and Statting, which was presented in 2006 at an ASHA conference, and it's also been detailed in Buchelin and Miranda's AAC book, which are in our references. I'm hoping that a number of you are familiar with this multi-tier model because it has been around for a little while, but I find it so very functional and helpful when we are considering AAC for this population. It is broken into 5 tiers. I'd like to talk briefly about each one of those before we go any further in the presentation. Tier 1 is really a traditional use of AAC, and this would be earmarked for those individuals that are really primarily unintelligible. They might have word utterances that are approximations or still very inconsistent, that really negatively impacts their overall communication. And they would likely need an SGD or a speech generating device with a low-tech board perhaps as a backup or as an additional tool. Down below, I just have a screenshot of Saltillo's word power pages to help you understand what we mean by more robust or a more complex speech generating system. In Tier 2, AAC for speech supplementation, this would really be what we'd be focused on for individuals that can produce one-word messages that are somewhat intelligible and gaining consistency, but they continue to have significant difficulty with multi-word productions. Their motor planning, their sound sequencing continues to be problematic, causing that to be unintelligible and difficult. And they would continue to benefit from a speech generating device or a low-tech board, but you may be moving them to something that is more supplemental, like the graphic below that has the alphabet in the center. That would be a topic type of board where around that alphabet there are topics such as it's about my family, or it's about school, or it's about my body. And then they may or may not be able to use the alphabet to start to spell the initial letter of the word they're trying to produce. That depends on their literacy. So for younger children, we may have symbols instead and have multiple pages for that. That crosses over into Tier 3, which is AAC for breakdowns. And that would be using AAC for those individuals that speak with about an 80% intelligibility rate, but they still need support to repair those communication breakdowns. When they're talking to unfamiliar partners, or when there's a longer narrative, or the context isn't known, and that intelligibility suffers a bit, then they do need some support or some tool that they can use to help get their partners on track. And that again might be that supplemental board, which is why it kind of crosses over both those tiers, or it might be a specific board that's primarily developed for that environment or that task or situation. Tier 4 is AAC for academics, and that would be for those individuals that continue to have delayed language and literacy skills. And the AAC that they have been using, hopefully along the way, and they've been developing their verbal speech, perhaps they're not using it so much for speech, but they may need it for those literacy tasks or those academic tasks so that it can help them with writing and reading development. Typically, voice output would be helpful in those types of situations to help associate that text with the voice output or the speech production. And then Tier 5 finally is AAC for practice. So again, if they've had an AAC system, then you might consider using that as a tool as their speech becomes stronger and more consistent. And there is, of course, a desire to have repeated practice, you might find that asking them to produce some words on their communication system and repeat those as a homework assignment or something that they do with their family member might be appropriate. But this would really be only for individuals who really aren't using their AAC system for communication. They might have it still because they've grown out of it more or less, but we could still use it as a tool. Quite frankly, when I'm looking at that AAC for practice, I really am looking at apps and not necessarily a full-bodied system for someone. Okay. Now, when we talk about making decisions about AAC in that multi-tier model, we talk about therapy and what we're going to do about integrating the decisions we've made for them into therapy. And here's the elephant in the room these days, and that is that many of us are not working face-to-face, side-by-side with our children on our caseload. And I have to tell you, I personally miss that desperately. I do get a lot of encouragement and feedback when I am with a child and I can see what's happening in their mouth. I can give them touch cues and help them and provide a lot of reinforcement. And we're moving to teletherapy for that. I'm learning that. That's a new thing for me, and it might be for many of you. Some of you might have been doing that for some time and are quite skilled at it. We can accomplish just as much successfully in teletherapy as we've done face-to-face, and I'm learning more and more about that. We wanted to make sure that all of you understood that going to teletherapy shouldn't be another barrier to using AAC when we are treating these populations. So we have 4 different models of how you could use your AAC supports in teletherapy, and the first 2 are here, the low-tech or no-tech manual communication boards, which obviously your children can show you, or you could do screen sharing of editing software. Many of the high-tech companies have editing software that you can download for free, and you can upload communication pages and share your screen with your child and show them what you're doing on the screen, and the family may be able to acquire that as well. The other 2 methods I want to just picture here and show you, and that would be where you might have a child, the smaller picture here on the left, have a computer, their board, a system, and they use manual communication boards or their AAC system to respond. So you can see that the child can see me in the computer screen. I'm in the upper left corner. There's a game that we're playing. They can see my hands on my device to model what I'm doing, and they're imitating that same on their device. In the clinician picture, I want to highlight that you see my hand because I am using my cell phone and I am using Air Server or Reflector or some other screen sharing program on my Windows computer to show my cell phone camera. And my cell phone camera is just live pointed at my device. So it's allowing me to show that as an additional screen. This next example would be somewhat similar to that, except here, the problem that I had in the previous picture was that I couldn't always see what the child was selecting. And in this example, we have the child with the computer, with the CAS or the chat editor software up on their screen that I'm sharing from my clinician screen on the left. And if you look closely at the left picture down in the lower left corner, you look closely at the right picture where it says clinician and look down in the lower left corner there, you can see a little picture of the child, and right below it you see a picture of their hand on their communication device. And that is being achieved by sending the family 2 logins to the video teleconferencing software. One login they do on the computer and the child's face is right there, and the second login the parent does on their phone and uses that phone as a participant and just simply points the camera towards their hand using their device. And so that way the clinician can actually see their hand in action. So there are some different ways to do that, and I hope that this helps you remember to incorporate that into what you're doing. Now, moving forward, we're going to continue to talk about therapy, and we're going to present some case studies here. And in doing that, I just want to mention that there is some research that we had referenced in the handout that really supports the use of speech generating devices and AAC supports. I want you to make sure that you go through that reference sheet and look at some of that as we go forward. Okay. So the first case study, and I'll try to be somewhat brief so we can continue and get through everything we have to share, is this young 5-year-old girl. And when we first reported on her, she was 5. And you can see the details of her characteristics. Really very little speech output from her, but the speech output that she did have was evidenced significant groping, significant inconsistencies, and she had overall global motor planning problems. We focused on improving functional communication and on increasing her speech sound repertoire. She went through an evaluation process, and we ended up with LAMP, Words for Life. And we also created a gesture dictionary for her, which I'll talk about in a minute. And then we also incorporated visual schedules and visual supports. So she had a dual focus, and that's what all of our children have had that we're going to be presenting. We're looking at this dual paradigm, and it's detailed really nicely in a perspective article by Uman and McCarthy in 2014, which is noted in your references. But we were looking at different verbal speech strategies, and of course these are all listed here, primarily a multisensory approach that we were using, with some scaffolding, accepting anything that she could say and working off of that, and of course using motivating activities. But the AAC strategies that we really want to highlight are the modeling and the aided language stimulation. And remember in my definition earlier, that was using the device as we're talking. So even when I'm working on those key targets and those key words, I am showing her where those are in the LAMP program. She has that dynamic display with that robust vocabulary to support her. And we also customized that to add some social phrases that she could use to help her more easily engage in games like "it's my turn" and, you know, "I don't read that to me," so that she didn't have to build everything right away. Now, she also used some gestures, but her motor planning was really not good for fine motor. And even though her family really wanted us to continue to focus on gestures, we found that they were very difficult to understand, hence the need for the communication dictionary, where we described what those gestures were and what they meant, and then what we did as a response. So consider doing that. That final step is parent coaching. And so again, we began to do more parent coaching. And in this environment now with teletherapy, that can be a game changer. So involve your parents in using the systems that you can provide or the manual boards that you can provide to the families. She would fall in that tier 1 because she did need traditional AAC due to the complexity of her diagnosis. Just to give you an update, 3 years later, her verbal skills are still limited, but she is imitating more, she's sequencing more sounds. True words still are not as robust as I'd like to see them, but her skill with her communication device is wonderful. She's constructing 4 to 6 word utterances, she's asking WH questions, she's using prepositional phrases, she uses it to direct Alexa at home, which is a wonderful communication partner that's really very forgiving. And of course, we've expanded that parent coaching to build more skill there. We'll continue to work on this dual focus and work on her voice as much as we possibly can.
Case 2 is a 4-year-old male with a diagnosis of developmental delay who began receiving early intervention therapy at 23 months. The goal of the services was to increase speech and language skills by targeting and incorporating sign and verbal speech strategies. Soon after he began using sign, his verbalizations increased. Unfortunately, as his verbalizations increased, not all of them were understood, and he began to scream, and there was an increased note of different behaviors that were starting to be exhibited. Because of those behaviors, they wanted to increase communication, so the speech language pathologist working with him at that time, introduced picture exchange. And then as she was introducing picture exchange, she wanted to use a mid-tech AAC system to allow for more expansive language. Once there was more expansive language and verbalization, she started introducing and using prompt techniques, which she was trained in, because she wanted to shape more of his speech to be more intelligible. So again, kind of using both of these strategies. So when we look at the different types of strategies that were used, or excuse me, the systems that were used, they use sign language in conjunction with prompt, in conjunction with low-tech and mid-tech systems. The treatment that was used, it was during these motivating activities, they focused on the verbal speech strategies such as focus stimulation and auditory bombardment, pausing before targeted words, pausing with expectation, producing words with more emphasis, and producing those at a slower rate. They also use tactile proprioceptive input with the prompt. When we're looking at the AAC strategies, again, sign is a form of AAC as well in conjunction with the verbal speech. They also incorporated parent coaching, and on the mid-tech systems and the picture exchange, they were incorporating words that match those targeted words. Looking at this client, we would fall under that tier 2 of that multi-tier level. 3 years later, he's a verbal communicator. He uses a pacing board to decrease his rate of speech while he's using those routine phrases. He is able to label familiar items independently, but he does rely upon a communication partner at times to decrease or stop some of those verbal perseverations. Low-tech and high-tech AAC are both being incorporated to allow access to more robust language, to increase his overall independent verbal speech, but to also decrease his verbal perseverations on certain words.
Okay, so our final case study is a little different than the other two as well. Again, a young female, 5 years old at the time that we first presented her, with a formal diagnosis. Again, that groping in sound production, difficult sound sequencing, but she was verbal, and she was really experimenting with her verbal skills and very persistent about trying to communicate verbally. She did have co-occurring language delays in her length of utterances, in her vocabulary. It was a much smaller lexicon, a smaller number of vocabulary words, but she also had co-occurring motor planning issues in her fine motor skills and her gross motor skills. Really energetic and engaging, loved pretend play, dolls and games. The focus of treatment for her was to improve those verbal speech productions and increase her skills in expressive and receptive vocabulary. She also went through an evaluation process because of her intelligibility and inconsistency, and in conjunction with the school, we started with LAMP, Words for Life, and did a trial with that, but moved to Touch Chat, and we all agreed that Touch Chat was a better fit for this particular child. She also used a lot of picture cards to help demonstrate mouth movements and shapes for different word productions. In verbal speech strategies, we again started with really a strong focus on different sound combinations and moved to multi-word phrases as soon as we could. And we used what I guess I would term a core word approach, where the sound targets that we selected to work on, we found functional words for her to use in her environment and really targeted those within therapy so that she could learn to say those at home and in her play situations. But they really focused on the targeted sounds that we were trying to shape. And she also used some sign. So again, her fine motor was more constrained, so we did have to modify that sign a little bit. The AAC strategies, of course, aided language stimulation and modeling. This was a big part of what we were doing in addition to all of those sound targets. So whenever we were working on particular sound targets, we were also selecting icons and messages on the device. And we were doing both explicit and implicit instructions. So sometimes we were just modeling and not requiring her to make any selections, and other times we were showing her specifically where to go and how to find those words because we knew they were more challenging, but she would need them. She, again, had parent coaching happening with her at home. I did want to put a shout out to a recorded webinar that Saltillo has on communication partner training by Jill Sunner and Matt Loud. So if you're interested more in that parent coaching format, please explore that, and you might find some additional help there. She would fall into that tier 2. We were really targeting the usage of the AAC as more of a supplemental support for her. It wasn't her total communication system. And so our work was over a longer period of time in building her skill and understanding of where vocabulary words were. 3 years later, she doesn't need an AAC device anymore either. She's verbal. She has just some minor articulation errors in her later developing sounds, and her language has grown more complex, but we still need to work on grammar and syntax. So when we talk about all of these different therapy cases and different ideas, and we're moving into this teletherapy world, we thought it would be great to give you just a slide of ideas, and it's in your handout as well, to not give up on those tangible toys that you can use. And I don't know about you, but I'm at home and I don't have a lot of these toys, so I have to rely on the families to have that. So I would do a parent survey and ask them what they have available that they could pull out and have ready to go. So don't forget about some of those tried and true things, or helping families make some of those. Ideas for online materials, we've included those here. There are so many things that are now becoming available in the online world to allow you to screen share and engage with the child, and we've listed a number of them here in your handout, and we hope that you'll explore those. Some have subscriptions, but some also start with free trials that you might be interested and able to do. But don't forget your AAC supports. Okay, so we want to make sure that you don't do that. A couple of other online materials that we didn't list here is one called Hello Kids that I just found recently through some of the students that I'm working with. It's online coloring book pages that you can print out or do online, and they truly are wonderful and have all of those Disney characters and superheroes and holidays. So just one more little piece there. Again, a shout out for another webinar that's coming up from Laura Enders, which I'm sure she will have 1,000 ideas, so I'd encourage you to also join in on that. In planning therapy, we included this reference worksheet. It's a planning worksheet to think about how you're designing your therapy session and to consider how you're going to integrate your AAC options and supports with the verbal treatment strategies that you're going to use. And so this is a completed one, and you can see it just has the AAC competency areas in the upper right corner that you can select. Those are what you're focused on. The general focus areas, a place for you to write objectives and about the environment or the situation. And then it's divided in half, that pink half and the green half, to allow you to detail different activities. And in the language section, which I particularly like because it helps me focus and stay in that narrow focus, I can list my sound targets. I can list my core vocabulary words that are verbal that I'm targeting. I can list my core vocabulary AAC words, the fringe vocabulary that I might need to know where it is in the device or need to know that I've got to work on that with the child, and any social messages I might want to include in the activities. Place for materials, a place for your AAC systems and supports, and some detail there. And then finally at the bottom, some instructions for yourself to remember how that teletherapy session is going to be set up.
With the information that's been presented in tonight's webinar, one thing that we can conclude is that integration of AAC into speech and language strategies used with children that have CAS can be an effective tool to support and build their communication. The multiple studies that are also included in the reference list supplement and support this integration and use of that. So with that, what we want you to do is we want you to engage in dialogue with your clinicians and families to think about incorporating AAC systems. We want you to continue to provide information that dispel the myths of those AAC myths that still exist. to create and share different communication supports such as gesture dictionaries or manual communication boards. We want you to continue to introduce or begin to introduce manual communication boards so that they can be used as language supplements. And don't forget about that computer simulation software that many of the companies have. We want you to explore and obtain an AAC evaluation. And if an AAC evaluation results in a trial, obtain a trial device from the resources that are local or that are known so that you can try those systems out. Remember that AAC is supplemental. It should be used early. It should be used often. And don't forget about the amazing worksheet that was just shared for integrating the use of AAC so that it can become integrated into therapy, school, or daily routines. So without further ado, here's a whole bunch of different resources. We wanted to note that this is not a comprehensive list. We hope that you found the handout that is with the course supplement or beneficial. And then here are some other resources on the next couple slides that we'll talk about.
So of course, the ASHA portal, Apraxia Kids website is a wonderful resource on all things with childhood apraxia of speech. In here too, different websites that you can go to. PRC-Saltillo now has AAC teletips, so that if you do want to investigate that further, it's a great resource. A lot of you will know about Practical AAC blog, AAC Language Lab, AAC Institute, RESNA for resources.
Many companies have free corresponding low-tech communication boards that are available for printing off of their websites, which can be used as great representation of language, regardless if there is or isn't a formal diagnosis of CAS. Some other options that could be used for temporary or maybe longer-term support include remnant books and gesture books, especially when the verbal speech may not be understood. And then alphabet boards could also be used to supplement said remnant or gesture books. Project Core has a plethora of information on there, including low-tech communication boards, professional development, and just so much more. And last but not least, Chat Editor or PAS software. Many of these free corresponding simulation softwares are available and can be used for printing off boards or using it during your virtual teletherapy practices.
And then finally, oh, I'm sorry.
Go ahead, Kathleen. Go for it. Go for it.
Okay, and then we just have slides on our references, which are detailed in your handout. And I just want to point out a couple of those great articles. The one by Luke here on the impact, which is a really new study that was done in 2016. Of course, the Uman and McCarthy work that's been done, and certainly the research that's been done by Murray and other investigators on reviews of treatment outcomes on CAS. And that would be concluding our presentation.
Okay.
Do we have any questions?
You too. So I'm going to go ahead and get started with some of those questions. We're going to run a few minutes over, but I just want to say that thank you for providing this presentation, but I'd like to get through the questions as well. So the first one, at what age should AAC be considered for children with CAS? And should a device be introduced immediately or a core board? And how does cognitive ability affect the choice of a core board versus device?
So Michelle, I'll take that one. I don't think there's a magic, there's not a magic age. It's really the need of the child. So I think if the behaviors and the speech and language skills that are being exhibited by the child are warranting an AAC system, that would be the time for an evaluation. You can start introducing AAC in a more of a trial or an exploration phase at that point in time, but I haven't found that there's a magic age. I've introduced it with children, as young as 2, and of course I've introduced it to much older children who've never had it, and because they've just been continuing to work on speech. So it really depends on the child's skills and abilities, and their cognitive processes. Those would be considered in an evaluation on how to arrange the vocabulary, how to present it, and again, help you with choosing targets and words to focus on. So that evaluation piece would be really important. And I want to put a plug in for another recorded webinar that Saltillo has from Heather Miller-Schwartz on AAC evaluation that you might find very helpful to move through that process.
Okay, thank you. Next question. They're jumping. Somebody asked about the supplemental topic letter board multi-tier model for AAC usage slide. So where was that from? Where was that supplemental board from?
That was actually a board that I created myself. So I'm happy to share it with anyone. So if they want to email me, I'd be happy to send them that particular file. But it's just a homemade board that I did for a couple of the students and the children that I work with.
Awesome. Can you explain gesture dictionary a bit more?
Sure. So in Practical AAC, where that picture of the gesture dictionary came from, Carol Zangari has a great little explanation of how to create that. But generally what it is a way to detail what a child's gestures are and what they mean or how they're being interpreted. And in some cases, we take photos of them doing the gesture and we'll put a photo in there. So we'll make the box a little bigger and put a photo. And we'll say, you know, this gesture, when the child taps their chin, they're telling you they want to eat. Or when that child is clapping their hands, they're telling you yes. And so we will describe what the gesture is. We'll explain, you know, our response to it so that people who aren't familiar could look at that gesture dictionary and understand what this child is doing when they're clapping their hands, they're saying yes. So having that documented is a really helpful tool for children who are really having a difficult time with their verbal speech and are using their body language to try to enhance that communication.
And especially if they have reduced motor abilities, some of our folks that we work with have, you know, approximations of signs, so that could also be utilized for that as well.
Okay. There's a couple about funding. So one of the questions is about how do you justify funding when it's tier 1? And so there's a couple of questions that are sort of related to funding in general. So how do you go about funding for this? And I think it's state to state, but do you have a generic?
Michelle, do you want to take that one?
Sure. So with the multi-tier approach in regards to that, we were viewing that, and Kathleen jump in here, more as like a therapeutic approach in regards to like what the AAC could be utilized for during that tier. Those tiers don't indicate a high-tech versus a low-tech system, but when it does come to funding, it is state-by-state specific. I'm happy to talk a little bit more if there's a little bit more information that's wanted.
Right, and just to elaborate on what Michelle said too, tier 1 is where the child does really need some strong vocabulary support that might not be easily provided through manual support. So they might need something like an iPad with an app or a dedicated device. And again, in that case, an evaluation would be warranted so that you could, you know, kind of narrow out what would be the appropriate option and then move through those funding stages. Certainly, again, exploring different options, but knowing that an evaluation is really a critical piece when you are making decisions about AAC for those populations.
Yeah, and that feature matching should definitely be included in that evaluation process as a really strong indicator to help guide the process in regards to what system might be best for that individual.
Can AAC be considered for an 11-year-old child with cerebral palsy and developmental delay?
Again, it would depend on the child's communication, current communication needs and what their speech production was like. So while, you know, looking at an 11-year-old with cerebral palsy, there's so many, just like childhood apraxia of speech, there are so many variables in how the child might present that I would defer to an evaluation where there's more history taken and there's more understanding of the child's communication needs and capabilities.
Yeah, and some of these questions that are related to funding, I would encourage you to reach out to local consultants from the various manufacturers to find out, how they can help you, because sometimes there's little bits and pieces that help you get through the loopholes in funding, if there are funding loopholes. So I would think that would be something to do.
Yeah. Or just to navigate the process, because state by state and is just so different.
Yeah. Do you conduct the evaluation trials with various features on devices, or do you call in local consultants to conduct those sessions?
I'll speak to the consultant part if you want me to.
Go ahead. Go ahead,
So,
Michelle.
So as consultants, we work for SGD manufacturers. So I'm also a speech language pathologist. So a consultant from said speech manufacturer technically cannot do or conduct an AAC evaluation, especially if that consultant is also a speech language pathologist. That would be a direct ethical violation according to ASHA. And in AAC evaluation reports that are going through funding, there is a specific statement in reports that need to be stated that the evaluator has no relationship or financial relationship with the manufacturer. What we do and can do as consultants is come into evaluation sessions by providing different devices and walking through the different features and settings of our devices with the speech pathologist who is conducting the AAC evaluation.
From my perspective as a speech and language therapist, I do, yes, AAC evaluations. And if I am looking at a new piece of technology, I definitely contact the consultant to learn about that system and to pose questions to them about features that I think I might need or need to know about based on the intake history that I've taken, maybe the observations I've done of the child prior to initiating that evaluation contact with the child directly with devices. So yes, I do them. I am not affiliated with a company, but Michelle, on the other hand, is a consultant, so she's there as a terrific resource.
Okay, so I'm going to wrap this up because we have gone over the time. I appreciate everyone hanging on and staying for the questions. And Kathleen and Michelle, this was great. You have lots of great feedback. People have mentioned using the dictionary to get started with AAC. So there are just like tons of great responses here. So I really appreciate you guys taking the time to do this. There have been a few people who've asked about the webinar that is coming up with Lauren Enders. So in the chat window, Beth has posted that link there. So if you want to look in the chat window, that link for that should be there. If you go to the Saltillo YouTube channel, you'll see the guest webinars that they've been talking about. I tried to post the link while we were chatting here, and it may not have been quite correct, but it goes to a playlist. So if you search for the playlist of guest webinars, you'll see those there, also on the PRC site as well. So we're in this together in all kinds of ways. So we appreciate everyone joining us. Can you go to that last slide where I had the final ASHA information?
Yes.
So I just want to say one reminder about submitting those forms within the 15 days and including today's date and the title of the presentation in the subject line of the email. That helps our team really process these ASHA forms because we've had so many trainings, and you can imagine that there are thousands of ASHA participation forms coming in. So to make sure that we're accurate, that really helps us out. And if you want to put your contact information back up, I just really want to thank you both for doing this presentation. It's been great. And thank you, audience, for being here with us.
I would just like to say thank you as well. We know it's a difficult time, and it's something that we're all having to work through, and we hope that this information has given you some more resources and some more incentive to keep working hard for those children that are in such need.
Yes, thank you. Ditto what Kathleen said.
And everyone stay well, please.
Yes.
Okay, thank you.
Thank you.
Thank you.